All right, well, welcome and thank you all for being here today. I'm Anne Marie Medeiros. I'm a member of the Southwest Clinical Trials Network Community Engagement Team, and we're so pleased to bring you this Stigma in Healthcare workshop. We're just so glad and amazed to see so many of you here today. This is our biggest event so far, and we're just so appreciative of the support and the interest from the community. It's really great to see all of you here. Typically, we get a lot of questions about CEUs following event. At this time, we're not offering CEUs. We hope to be able to do so in the future, but today we'll send out a certificate of completion to all of those who have attended the training. Pleased to introduce our phenomenal trainers today, Mindy Vincent and Erin Fanning Madden. Mindy Vincent is a licensed clinical social worker specializing in mental health and addiction treatment and is the founder and executive director of the Utah Harm Reduction Coalition. She started the first legal syringe exchange in the in the state of Utah, and has done extensive work in harm reduction, drug policy, opioid overdose prevention, awareness, and treatment, and continues to work to educate the community, stakeholders, and policymakers about therapeutic substance use and harm reduction. Ms. Vincent is certified in psychedelic-assisted therapy, as well as several other cognitive, behavioral, and trauma therapies. Mindy is also the host of the podcast Therapeutic Madness, which is great, and owns a private practice called Life Changing Counseling in Heber City, Utah. She received her bachelor's degree from the Utah Valley University and her master's of social work and master's of public administration from the University of Utah. And second is Erin Fanning Madden, and Dr. Madden is a faculty member in the Department of Family Medicine and Public Health Sciences at Wayne State University School of Medicine in Detroit, Michigan. Her research explores substance use amongst marginalized populations and social factors affecting healthcare for people who use drugs. She has published research on primary care programs for people with co-occurring mental and substance use disorders, racial and ethnic differences in naloxone prescriptions, and professional attitudes towards medications for opioid use disorders. Dr. Madden received her doctorate in medical sociology from the University of Wisconsin-Madison and her Master of Public Health degree from the University of New Mexico. So thank you both so much for being here today. We're so glad to have you, and I will turn it over to you.
Thank you so much, Anne Marie. So I'll get us started. So Mindy and I have been working together on issues related to stigma and substance use since about 2018, I think. We met when I was giving a training on harm reduction in Utah, and Mindy provided so much great personal experience of doing harm reduction work in the field in Utah that we decided to actually start doing trainings together. So we've been doing that for a few years now. Mindy, do you want to say anything more about yourself other than what Anne Marie offered?
No, I feel like that was already far too long.
Okay, so I'll just introduce us a little bit. So this is a substance use stigma workshop. It is interactive. We're going to be presenting kind of on the front end, but there's going to be two opportunities to participate and interact. So please stay engaged, even if I start to bore you a little. There'll be time for y'all to talk and everything. So just to disclose, we have no conflicts of interest to disclose, Mindy or I. No one's paying us to do this. We just are interested in this topic and working on issues of stigma related to substance use. So to give an overview of this workshop, we're going to start with Mindy giving sort of an introduction to substance use stigma, the general concepts in this area. Then I'm going to lead us in an intervention research demo. We're kind of going to show in a very small example what intervention research means so that we can start to talk about what is the current knowledge of interventions that might be promising for reducing substance use stigma. We don't know a lot about this area, and that's part of why we're doing this workshop, is to figure out what do people in the field kind of think about this sort of very young, very new, very small area of research. What could work, do you think, in your clinics, your facilities, your agencies? Because that has not been a conversation that's happened very much. A lot of this is happening in research without much conversation with the community. So we're going to do that demo. We're going to go over that small body of research on current, oops, someone is sharing their screen who's not me. Okay, hold on. Yes. Okay. Sorry. Okay. So we're going to go over this small body of research, and we'll talk kind of about what we know, which is not a ton. Then you'll have the opportunity to go into breakout groups to reflect on the sort of the handful of stigma interventions we have, what you like about them, what you don't, what are some of your ideas for other interventions that might work. And then we'll have a larger discussion where we report back. So that's how it's going to look today. It takes about 2 hours. So the two sort of areas where you'll be able to interact and give feedback are the intervention research demo and then the breakout groups and reporting back period. So I'll hand it over to Mindy, though Mindy, I'll just control the slides for you. Just let me know when you want me to advance them. You're muted.
I don't know if I'll ever get used to Zoom. I'm sorry, everyone. It's been years now that we've been on Zoom, and yet I still forget to take it off mute. I was just saying I really like this picture, and so we could look at it for a second and then move on, because there's not much to say about the introduction slide other than we like the picture. And click. Okay, so the definition, the technical definition of stigma is when an attribute incites prejudice and discrimination towards individuals and groups. And prejudice is negative thoughts toward a group. Discrimination is negative actions toward a group. And we see stigma working in substance use. You see stigma in so many layers, in so many different ways. And I wish that we were in a format where we could just openly talk about this, because I know for sure that there's actually people in this room who have significant experience with this, who actually taught me a lot of the work that I do today. And I wish that we could all just talk about it, because it's so impactful in people's lives. And it's, in my personal opinion and in my clinical opinion, it's one of the greatest barriers to people's abilities to recover, because stigma becomes internalized. And when somebody believes something bad about themselves that other people have told them, then it's much harder for them to move forward. But we're going to get to that in just a second. So some of the ways that stigma operates in healthcare, there's condition stigma, where there's stigma toward a patient due to their diagnosis. We used to see this much more with HIV, patients with HIV, and then people with substance use disorders. This happens all the time in emergency rooms, when people are seeking regular healthcare and they have a substance use disorder. Some valid and justified, some not, but either way, that most providers have some kind of feeling about, at very least, what kind of medications they're going to prescribe them or what kind of interventions, right? So that is a stigma toward their condition. Intervention stigma is stigma towards certain types of interventions. It says controversial on the slide, which is always such a little catchy term, because methadone, medication-assisted therapy, specifically syringe exchange, these programs are only controversial because of how people feel about them. They're not controversial in science. The science supports these interventions. And so because of these stigmas, that gets in the way of being able to implement these programs that are health-based and that have been shown over many decades. I wish I'd started the first syringe exchange in the United States when somebody said that earlier, but syringe exchange has been going for over 40 years, right? So we know that they're effective interventions, but for a multitude of different reasons, they end up controversial. And so that gets in the way of being able to implement these interventions that are life-saving. Provider-based stigma, which is just stigma amongst healthcare providers and staff, which results in people not treating people, or sometimes I don't see it too much anymore that it's so brazen that people are like, I'm just not going to treat you. But I think that it does impact how people treat somebody. However, when we're talking about substance use disorder treatment, this actually does happen all the time, because there's lots of people who refuse to treat people for substance use based upon a myriad of factors. Like, you could be on medication-assisted therapy and be unable to be treated. You could be on Adderall. You could need to be on anti-anxiety medication, medical cannabis. There's a whole array of reasons why a substance use treatment provider might deny you care. And we allow that too, which that's, in my opinion, as a clinical provider, I find that to be problematic. Is it term difficult to engage drugs? Oh, if I'll get distracted if I read the comments. So Aaron, if you see something in the comments that we need to address, will you stop me? because I have a little bit of ADD, so I can get easily distracted by that. And then structural stigma, which is stigma created by policies, and it's held by officials who carry out policies. So I live in Utah, where, you know, we're the most conservative state in the country. And we see this in our laws a lot. We had a really hard time getting medical cannabis passed, not through the people in our state, through the legislature, because of this structural kind of stigma. You see this in laws that are made, such as drug-induced homicide bills, where people get charged with murder for selling drugs to somebody who then overdoses from those drugs. I mean, laws just criminalizing drug use fall into this category as well. Oh, but like forced treatment. We had a law that almost passed here that would have allowed people to force people, like civilly commit them into treatment, saying that they couldn't care for themselves. And that's a big thing to say. You're taking away somebody's civil rights. So it's a big deal. Oh, the difference in sentencing between crack and cocaine. That's a very good one. That one is just as that one used to be sentenced 100-1 crack to cocaine, powder cocaine. Now it's still sentenced 18 years to 1. So if you were caught with a gram of cocaine, you would likely do 18 years, where if you were caught with a gram of powder cocaine, you do like 1. So, okay, Aaron, I could go off on those things all day long. So we will have to rein me in. So I said this a little at the beginning, stigma operates at multiple levels, and I'm actually going to go from the higher level and go inward, because to me, as a clinician and as a person who's recovered from a substance use disorder, I truly do find that the most damaging, all the stigma is damaging, right? But the most difficult stigma to overcome is the stigma that is internalized, you know, because like I said, you know, when I was using substances, I used to tell people, you know, you could never hate me for the choices I've made as much as I hate myself, right? So like the whole world could have stigma toward me and think terribly of me. But once I believed that about myself, then it was really hard to do something any different. So through higher levels, it's the stigma, like we already talked about, through the public. We see this toward people who are struggling with homelessness. So our unsheltered population, this happens to them, and many of those are substance users or struggle with mental health issues. You know, through our laws, through government, DCFS, our correctional institutions. I mean, it just goes all the way from the top, all the way down. You know, I mean, when you look at the war on drugs, just all of it, that's the highest level it gets to, you know, so, and that's been going on for decades. And when you think about like the commercials that have been put on TV, the educational campaigns, that kind of stuff, the kind of stigma those have induced, you know, when I was a kid, I really thought there was, you know, a crack dealer whose head turned into a snake, you know, and like, that's what drug dealers looked like. And it turned out that wasn't true. So then when I did try drugs, nothing that anybody had told me about them were true. So therefore I threw out, even if they gave me any good information, I certainly didn't hold on to any of that, because I found that the information they gave me wasn't true. So middle levels of stigma is stigma amongst people in their social network, with their doctors and providers. I would say that within your own small community fits into this as well. So, and we see this in families too. So, I mean, I live in Utah, so that's where my reference point is. And we have a very strong religious component to our state. I think everybody knows that. And you see this a lot because substance use is against the word of wisdom. So is smoking, drinking caffeine, coffee, all that kind of stuff, right? And there is a very loud stigma amongst family, within the communities, toward people who use anything that's against the word of wisdom. And it ends up isolating people, and you see people, their lives progressively, you know, getting worse because they're becoming more and more disconnected from the protective factors and the protective people in their lives because of this middle level kind of stigma. And then the lowest level is stigma that's internalized by people who use drugs. I've already talked a bit about that, but that's, you know, it's interesting because as I treat people, and even as I was going through treatment, right? So I was always taught that I owed an amends to society that I would never be able to repay, that I owed a living amends, and that can never, which automatically puts me in a place of always bargaining for my worth and my worthiness, right? And that's what this does to people. And then it also makes it so that you believe yourself that you deserve to be punished for your addiction. So then not only, we call it accountability, we disguise it in the word accountability, and so then not only, so now today as a harm reductionist, as I'm trying to tell people that they deserve compassion and love, it's very hard for people to accept that because we've been taught always that we deserve punishment. And that until we hit rock bottom, until it's hard enough, till it's painful enough, that we won't change. And that's just not accurate. And in fact, those interventions often cause more pain, more discomfort, more inability and barriers to being able to get to a better place, right? Next slide. So some of the effects of substance use stigma beyond what we've already talked about, it does worsen social conditions. So this is another thing. We have all sorts of laws that target housing, employment, education. All three of these get targeted by substance use. So if you've ever been convicted of substance distribution, you're likely not eligible for a federal Pell Grant, which is how many people, especially from low income housing or low income families, end up being able to go to college. It's how I was able to go. People can get U8 at work all the time and can be terminated for that. People often have to submit to a drug test to even gain employment, whether somebody uses substances or not may have nothing to do with the type of employment they have, first of all. Second of all, you don't know that they're using drugs at work. And, but these are just some of the things that we just are like, well, people shouldn't use substances at all. So it doesn't matter what the circumstances of them are. We're going to prevent them from getting employment, education, housing. There's even in, like when we're creating kind of like transitional living for people, sober living, usually sobriety or abstinence is a requirement of that housing, right? So when we're trying to address these unsheltered crises throughout the nation, but we're requiring people who haven't done the work to be able to remain sober, we're requiring them to stay sober in order to have housing, we're setting them up to fail. And how can somebody really move forward in other areas of their lives if they can't even take a shower, if they don't have a bed to eat in, if they don't have food to eat, right? If people's basic needs aren't met, it's awfully hard to move further, right? So making these things contingent upon recovery from a substance is just not fair. And people who have heard me present before, I feel very strongly about the fact that it's very alarming to me that substance use treatment seems to be the only treatment I know of that we require the outcome before the work has been done to get there. It's very common to hear clinicians say, well, until you get sober, there's nothing I can do to help you. Until you stop using, there's nothing I can do to help you. I'm not sure what I went to school for if I can't help you in your darkness. If I can't help you while you're engaging in the behavior that you don't know how to get out of yourself, then I'm not really sure what use I am to you. And so I think we need to switch that around where we're willing to help people while they're engaging in undesirable behaviors, because one, they deserve it. And two, because if they knew something different to do, most times people would, right? But then we also can't hold things that make people's lives better hostage from them until they behave the way we want them to. That's just inhumane, in my humble opinion. It does worsen healthcare quality for so many reasons. People who have substance use disorders don't like to go to the doctor typically because doctors aren't very nice to people who've had substance use disorders. I have been recovered for 15 years and I've had the same primary care provider for over 10, probably 13, right? And she was super hesitant about prescribing me 2 milligrams of Valium, which is just kind of crazy. And I understand her hesitancy because nobody wants to feel like they're responsible for somebody else's downfall or something, right? But that would not even be a question had she not known I had a history decades ago of substance use disorder, right? So for people who are newer in recovery, it's even more likely that they're not going to get medication that they need oftentimes. And it's just, through the disease concept as well, we don't allow people room to recover. So once you've identified as an addict, that's like kind of in your permanent history, and people really do expect you to disclose that to your doctor for now until the end of time, even if it means that you're not going to be able to get medication that otherwise would be completely medically appropriate to be prescribed. And it does contribute to discharges against medical advice, because when people don't feel like they're being heard by their prescriber anyway, then there's a lot of reasons why people would discharge, right? And so, and when you're telling your prescriber, I have this problem and I need more than ibuprofen, and they're still not willing to help you, even when it's appropriate, then that makes you not want to seek help either. It worsens patient health and behavioral outcomes. It promotes higher levels of substance use and riskier substance use. Because if people, well, and if this is in different areas too, because if somebody is going to a provider and drug seeking, if they don't get it there, they're going to get it somewhere else. And that is part of the problem. And I know not everybody likes that idea, but safe substances are often what save lives, right? So when we put people in a position where they don't feel like they have another choice, they're going to do what they have to do, right? And we as providers have this opportunity to maybe intervene in that if we have an open mind, and sometimes when we have opener policies. It worsens mental health symptoms for a multitude of reasons, and worsens HIV treatment adherence and increases HIV symptom severity. If people aren't complying with their HIV treatment regimen, then obviously their symptoms are going to return. They're not going to be non-detectable anymore. And that's just sad, because when we can get a disease or an infection like HIV down to non-detectable, we need to do everything we can to help people stay in that place, in my opinion, as well. Ding. That might be my last little slide. Okay.
Yeah, thank you, Mindy, for that overview. Is there anything else you want to add before we do the demo?
Just be nice to people. That's it. Just be nice.
Yeah. So, I mean, Mindy gave a great overview of how important stigma is. Stigma is not just hurt feelings. Stigma matters for health outcomes, for services. It's a really big problem. Only recently been given a lot of attention. I mean, sociologists came up with the idea of stigma decades ago, but it's only in the past 5 to 10 years that there's been any sort of funding from the government to pay attention to how do we reduce this stigma. So I think everyone in the field, the substance use field, knows that this has been a problem. Unfortunately, the research, as usual, lags behind what people in the field know. So,
and I just do want to say one thing is that, sometimes there's some types of stigmas toward certain groups of people that it's absolutely condoned by others. It's condoned by society, and substance users and people experiencing homelessness. Those are two groups of people that absolutely get slayed with stigma and with prejudice, and we allow it. A lot of times we allow it, and a lot of times a lot of people in society either look the other way or they endorse it, and so what I just think about, being the change you wish to see in the world. And there's this thing I've seen that says, I often wondered why somebody didn't do something. And then I realized I am somebody, so every time we look away when people are engaging in stigma, we're allowing that to continue. And if we're not saying something, not only are we're just as guilty as the person who's doing it. So I'd encourage you, if you're somebody who wants to see stigma change, make sure that you speak up as often as you can when you see it, in a kind way that can be heard, because when you attack people, then we're no better than the people who are attacking, but also then people can't hear what we're saying, and love's not going to change if we're not responding with love ourselves.
Great. Thank you, Mindy. Yeah. I mean, so the big question in research now, right, is we know the stigma exists. People in the field have been telling us this forever, but what do we do about the stigma? Like, what are effective interventions? So that would mean like programs, mechanisms, policies. What can we do about it that's effective? So that's the question that intervention research is trying to answer about stigma. So before we get into what is the research saying, we're just going to give an example of what intervention research kind of looks like by doing a sort of mini intervention with you all, with the audience. So what this is going to look like is you're going to answer a series of questions, which is how we basically collect what's called baseline data. So when we do an intervention research project, we want to see if the intervention changes the data from baseline to data we collect after the intervention occurs. So we're going to ask you all a bunch of questions, and this is going to be our baseline data, and then we're going to introduce an intervention. So This is a pre-intervention poll. We're going to ask you a series of questions, and you're just going to give sort of your gut reaction answers. So these questions are, about your sort of willingness to have different types of social interactions or connections with someone with a substance use disorder. Anne Marie, do you want to say anything about the polls before we start them?
No,
don't-
I think they're gonna, oh, Christina does though.
I'm going to pull them up and they are multiple choice, so you can select as many as you want to.
So your answers are confidential. We're not going to share any individual person's answers. We're just going to add them all together. So don't worry about anyone seeing your answers. So the first question is indicate your agreement with the following statement. So agree or disagree. So I would be willing to marry someone with a substance use disorder. Second one, I would be willing to have a person with a substance use disorder as my neighbor. I would be willing to have a person with a substance use disorder as my colleague at work. I would be willing to let someone with a substance use disorder be a caretaker for my children for a couple of hours. And the final one, I would rent a room to someone in my home. In my home to a person with a substance use disorder. So there's no right or wrong answers. This is just to show you how intervention research works.
Somebody
So
asked a
it's-
really valid question though,
Is this
about if
active?
they're in an active substance.
Yeah,
use
yeah,
disorder.
thank you.
That is a real different
Like,
situation.
is it
sometimes.
active or in recovery?
Yeah.
So whatever you think of, I actually can't answer that because that's part of the intervention.
Oh,
So whatever you think of when you think of someone with a substance use disorder in general, that is part of the intervention. So you're smart.
oh man, that's crazy. Okay.
Hmm.
So we'll just give about like 20 more seconds for people to finish up answering if they want to. Okay, so it looks like about 100 people out of our 115 or so participants answered. So we're gonna end the poll and we're not gonna show you the results yet. Okay, that's coming later. So here is the intervention. The intervention is that we're going to read this vignette of a particular person with a substance use disorder, just a scenario, and then you're going to answer the same question you just asked, but about this particular person. Okay, so I'm going to read the vignette. So Mary is a white woman who completed college. A year after college, Mary went to a party and used heroin for the first time. After that, she started using heroin more regularly. At first, she only used on weekends when she went to parties, but after a few weeks, found that she increasingly felt the desire for more. Mary began using heroin 2 to 3 times weekly, and she spent all of her savings and borrowed money from friends and family in order to buy more heroin. Each time she tried to cut down, she felt anxious and became sweaty, nauseated, and also could not sleep. These symptoms lasted until she resumed taking heroin. She often was absent from her commitments, and her friends and family complained that she had become unreliable. After 6 months of living this way, Mary's family encouraged her to see a doctor. With her doctor's help, she began taking buprenorphine, a treatment medication. After 3 months of treatment, she felt good enough to start searching for a job. For the past 3 years, Mary has received steady treatment and her symptoms have been under control. She now lives with her family, works at a local store, and enjoys spending time outdoors and taking part in activities in her community. So we're going to ask you the same questions again, this time about Mary. Of course, the first question, would you be willing to marry someone like Mary? regardless of your sexuality? Please answer that question. And the other ones, it's the same questions, but consider someone like Mary. So someone who has been responsive to treatment and is on their way to recovery, or maybe is recovered, depending on what your definition of recovery is. So we'll bring up the poll again. It's the same thing. Do you agree or disagree with these statements about Mary in particular? So we'll give just a couple more seconds for anyone else to answer who wants to. We're about 100 people out of the 115 or so who are on. So we're pretty much at where we were at for the baseline data. Okay, I think we can close the poll. So we're going to show the results in a minute, the baseline versus your new results, but I'm just going to say a couple more things about intervention research before we show the results of our intervention demo. So to just give an overview of the intervention we just did, the sort of mock intervention, we have, the pre-intervention poll. We gather that baseline data before we do anything or present anything to you. We just want sort of an impression of people's attitudes towards people who use drugs, right? Then in the second stage of intervention research, we implement the intervention. Here, the intervention is not, like a new drug or a new program. It's just a vignette depicting an individual who is effectively treated for an opioid use disorder. And you read that, that's the intervention, right? It's not a particularly invasive intervention or anything, but it is an example of an intervention. So this vignette was actually used in a study. I just shortened it a little bit, but it's actually a vignette used in a study by researchers who were looking to determine whether presenting substance use disorders as treatable conditions affects stigmatizing attitudes. And they used the measures that we presented. The measures we presented are a stigma measure called the social distance scale. And it sort of measures how distant you want to keep people who are maybe from a stigmatized group. Is it not very distant at all? You're okay with having them in your social circles? Or do you sort of have some hesitation there and want to keep them away? And that's one way of measuring stigma. But again, it's just the attitude measure. And as Mindy said, right, stigma is not just attitude, it's also actions. It's discrimination as well. So it doesn't fully measure stigma, but it's a measure. So then after we show the vignette, we do the post-intervention poll to see if the answers changed, right? So the stage 4 is to assess whether the intervention changed the baseline to the post-intervention responses to see if it had any effect. So of course, right, this isn't that complicated of an intervention. I would say it's not the most, it wasn't the greatest study either, because it's kind of narrow in how it thinks about stigma. But in general, right, intervention research is a study that implements some type of new procedure or agent in order to test whether it changes an outcome of interest. So it could be like what we just did, where we test whether depicting successful treatment of a patient changes measures of stigma. It could also be something like testing whether requiring primary care doctors to do a substance use screening increases referrals to treatment, or if our outcome of interest is that referral measure. It could also be something like testing whether providing naloxone to people released from jail reduces post-release overdose risk. So our outcome of interest is that overdose risk measure. So the goal of intervention research is to identify some mechanisms that improve health services and patient outcomes. And then the real goal, though, is not just to show that something works. but is actually to have those things that work successfully adopted into community services. And this is where the stigma research has really fallen short. Not only do we not know a lot about what reduces stigma, we almost have no idea of what people who work in community services actually think about any of these interventions. That's part of what the workshop is about today. It's getting your reactions and feedback on the little bit that we know about how to reduce stigma. So we're going to show the pre and post intervention poll result just so you can see, did the vignette change your attitude? Did this intervention produce a change? And if it didn't, that's okay too. That's an important finding to know what doesn't work as well. So Christina or Anne Marie, do you want to share the comparisons?
Yep. All right, can you all see that?
Great, thank you. So it looks like, right, in the pre-intervention to post-intervention for the first question, we have an increase of 10% saying they agree that they would marry someone like Mary compared to maybe someone who's not clearly being treated, or you're not sure whether they're treated successfully or not. For the second question, as your neighbor, a very small change, right? So 89 to 90% change. So people were pretty comfortable with that already. The third question, willing to have a person with a substance use disorder as my colleague, a 6% change. So 84% agreeing to 90% agreeing. The fourth question was a caretaker for my children for a couple of hours. So a big jump there, 22% to 49%. And the last question, another pretty big jump, renting a room in your house, so 25% to 54%. So you can see that the vignette actually did have an effect. Of course, we're not measuring statistical significance or anything here, but just from a casual observation of pre to post, we can see that we did something to change your minds, right? That we presented substance use in a way that changed how you felt about it. So changes that attitude piece of stigma. Thank you so much, Christina, for sharing that. I'll put the slides back up. Okay, so I think we have time to take a question or two right now before we jump into all the interventions the handful of interventions, I shouldn't say all of them like there's a ton, but the handful of interventions that exist about reducing stigma. So I don't know what the best way, if people will, Christina, what do you think the best way is to maybe accept some questions? I forgot to ask you about this.
So I'm happy to keep an eye on the chat.
Yeah, we have some hands up too. I don't know if you.
Okay, so Michelle Miraman raised their hand.
I was just wondering, would you guys be able to send out a copy of the PowerPoint like you did with the harm reduction one?
Yeah.
Awesome. Thank you.
Any other questions at this point? Okay. So I'm going to go over the current knowledge of substance use stigma interventions that we have. Like I said, the state of the knowledge is not amazing. Research is behind in this area. So there's kind of three broad areas of research with one really dominating. And so I'm going to focus on just those stigma interventions that are focusing on health and social service professionals. So thinking about that provider-based stigma, because that's kind of what the CTN and me and Mindy are most interested in working on. Though, of course, like public stigma matters, we care about that. But in terms of thinking about where can we test out interventions, where can we maybe see what works, working with healthcare facilities and social service agencies is a little easier actually than trying to change and measure public stigma. So the big area of research has focused on education and training interventions to reduce stigma. And there's been a little bit on what's called interprofessional collaborations, and I'll say what that is in a minute. And then very, very little on government and organizational policy changes that could reduce stigma. So the biggest area of research, again, is this education and training. And within that, what we see is a lot of education and training interventions that focus on a technique called contact-based education. And actually, Mindy and I do this work as well. So this is when there's an educational curriculum or a training that includes people with firsthand substance use disorder experience telling their personal story. So people are talking about their recovery experience, their substance use experience, trying to humanize, right, substance use disorder, people who use drugs, and sort of incite empathy in the audience members. This could be done through, videos of people telling their stories, but also can and often should be done in person as much as possible too, for that interactive element. So Mindy and I do trainings like this. We've done several in Utah where Mindy is the contact-based person, right? Mindy tells her story about engaging in substance use, but also doing harm reduction work, and what that's like, and being on the receiving end of stigma, and that as a part of a training that we do for people who work in health services and especially treatment. Mindy, would you want to add anything about our use of contact-based education? Okay, no. So this is the most common intervention. We have a training where we tell people about people who use drugs and harm reduction, and we kind of bring in an individual with that firsthand experience. That's contact-based education. Other types of educational interventions, and these can be combined, it doesn't have to be contact-based or critical reflection opportunities. They can be in the same training, but our training opportunities that use what's called critical reflection opportunities. So this is where learners sort of reflect, analyze on how they think and act towards patients with substance use disorders, and ways to get people to reflect on themselves are things like having them engage in role play and analyzing that, case studies, engaging in discussion, and then also doing like individual journaling and such. This allows people to not just sort of like be in a training where information's coming at them and they might not be thinking about how does it affect my work and what I do, but actually having opportunities for them to think about, what do I do in my job that maybe is stigmatizing that I didn't realize? So giving people the opportunity to do that self-thought and thinking. Another thing that has been shown to work in trainings to reduce stigma is improving providers' skills for optimal patient communication. Typically, this looks like providing motivational interview training, where providers are taught about how to use motivational interviewing techniques with their patients and clients. Mindy, do you want to say anything about motivational interviewing and how you've used that too in your work?
Well, motivational interviewing is just, it's one of the best things that we can do to help people figure out, because many people know what they want. They know what they want the outcome to be, but they don't know how to get there, right? So if we can engage them in change talk, so we just put in change talk. Thank you, Abe. So when we can engage people in change talk, and when it's coming from them through techniques of motivational interviewing, we can help people identify what they want to do and how they can get there, as well as what are some of the barriers that are in their way, how can they overcome those, what can help them become more motivated to do it. And when people start to move forward in things anyway, that seems to cause a natural motivation, because people are like, whoa, look what I can do, you know? So I could go on all day about motivational interviewing. It's a wonderful tool.
Great, yeah, and a lot of clinicians maybe are like, I don't have the skill set to work with this population, or social service providers feeling like, I don't know how to help this person. They don't want to change, right? Giving them the skill set for having those conversations productively, and motivational interviewing is an evidence-based, technique. Providing people with those skills can help reduce stigma, make them be more willing to work with the patient population who uses drugs. In addition to motivational interviewing, communication skills, reflection techniques, and contact-based interventions, we also have some evidence that increasing the knowledge of science behind evidence-based practices reduces stigma among professionals who work with individuals who use drugs. So that could be things like explaining the neurobiology of medications for addiction treatment. So methadone, buprenorphine, naltrexone, there's a lot of misperceptions of how these medications work. I've done a lot of qualitative research with providers where I hear providers, and I mean, I'm a sociologist, I'm not a clinician, but I hear providers say things that are wrong about how these medications function. So improving that knowledge can reduce stigma. Also improving the knowledge of treatment and harm reduction effectiveness. Like Mindy said, there's decades of research on this stuff, but not everyone is aware that that's the case, unfortunately. So making people aware of that. There's also possibly a strategy, though there's not great evidence for this, that increasing sort of the awareness of the need for substance use interventions in the local community might reduce stigma. So this is kind of countering that myth. Oh, we don't need that here. My neighborhood, my patient population doesn't have this problem. I don't need to work on this or know about this. So doing things like showing local or regional overdose trends can kind of help to show, no, actually those services are needed here. We do have this problem here. But again, there's not great evidence of this intervention working. In terms of non-educational interventions, there's something called interprofessional collaborations, where there's some evidence that this could reduce substance use stigma. And by that, we mean creating formal partnerships between people who do evidence-based substance use work, typically in medication for addiction treatment or harm reduction providers, linking those two groups with people who work in either social services, correctional services, health, or other agencies, that sort of creating coordination, discussion, and collaboration between people who work very directly with individuals who use drugs and these other social services can actually reduce stigma among the people who work in those other health and social services. So things like establishing a monthly or quarterly meeting with key staff from both of those areas, the substance use area and the health and social services area. And then there's some sort of more involved models where people will do sort of planning, coordination between their agencies. So making sure they have a referral program set up between, for example, corrections officers working in probation and parole. There's a model that has them coordinate on a monthly basis with MAT providers to refer patients to care. That has been very successful. So planning that type of coordination and maintaining it has been shown to reduce stigma among those correctional officers, as an example. Government and organizational policies, like I said, there's not a ton of great research here on how to reduce stigma with these. One example, though, that has been successful is increasing explicit organizational leadership support for harm reduction treatment and care for people with substance use disorders. So by that, I mean like your chief medical officer or other sort of high up people in an organization are saying, we need to work with these patients. Here's some programming we're going to try to work on, right? So very explicit and clear steps to support the use of evidence-based interventions and care for people who use drugs. A possible strategy that we don't have great evidence for this would also be eliminating explicit or implicit policies that exclude patients treated with MAT. So for example, in Texas, for a long time, it was very common. So I used to do research in Texas. It was very common for inpatient residential treatment facilities to deny people treated with methadone or buprenorphine from services. The state decided to create a policy that banned that from happening, but that's never been evaluated to see if it actually stops inpatient facilities from refusing those patients. And if, you know, the people I know in the field are telling me the truth and what they're seeing is common, then that's not, the policy is not necessarily making a change, unfortunately, that this type of refusal of care for people treated with methadone or buprenorphine still occurs in residential treatment. So we don't know really if that works, but it's a possibility. So other possible stigma interventions are things at the government and organizational policy level would be things like maybe requiring all eligible prescribers to obtain a buprenorphine waiver. That could potentially reduce stigma. Increasing visit times for patients with substance use disorders. So sometimes, you know, providers, social service employees don't want to work with people who use drugs because their situations are complex and time consuming. People only have 15 minutes with a patient. For a healthy patient, that might be sufficient. For someone with the complex social and health problems that can accompany substance use, 15 minutes might not be enough. So a policy that allows a longer clinical interaction time or more time with a client, if it's not a clinical environment, could potentially reduce that stigma because clinicians or other providers would feel like they have the ability and the bandwidth to really get into it with the patient and determine what is good care for them. Other interprofessional collaborations that might work would be like increasing the use of teams with community health workers, peer support, or social workers to care for people who use drugs. So it's not just on, like, for example, clinical teams with a nurse and another type of provider to do all the work with that patient, that they have someone else that they can talk to, a peer support person, community health worker, social worker, who's able to respond to maybe some of the social needs or respond more quickly via text message or phone call than a clinician would. So these are possible interventions. We don't know if these ones would work. There's some evidence that they might. But of course, there's barriers to all of these interventions. So some of the ones that have been acknowledged, and probably you're thinking of others, is that, of course, all of this is going on in the context of the ongoing criminalization of drug use. That's really a root cause of stigma, is that we say people who use drugs are doing something illegal and that we have the right to arrest them and incarcerate them for that use. That's a stigmatizing approach to substance use. And we can only do so much training to reduce stigma in that type of context, but it doesn't mean we shouldn't do training and other interventions. But we have to acknowledge that the criminalization issue is not really going to go away and is always going to be a driver of stigma until we really can address that. And how you address that is really difficult. There's also, of course, the high regulation of interventions that address substance use. So things like DEA monitoring of methadone and buprenorphine, that makes people maybe not want to engage in buprenorphine treatment because I don't want the DEA breathing down my neck, right? There's also local, state, and federal policies that limit the locations of methadone clinics. So, and communities, right, will mobilize against a methadone clinic being located in their neighborhood, for example, and not in my backyard, NIMBY sort of situation. Local and state policies can also constrain syringe programs. We're seeing a reemergence of that in states like Indiana and New Jersey, where local politicians are banning syringe distribution practices that are evidence-based, right? Just like local officials saying, nope, not happening here. That's also common in Texas and localities. Also a lack of buy-in or interest among facility decision makers. So we said, a few slides ago that one of the things that works is when decision makers are wanting to engage patients who use drugs. Well, if they don't, even if a clinician kind of wants that patient population, your leadership isn't supporting it, it might still fuel stigma in your organization. Also a lack of buy-in or interest among providers. Providers not wanting to work with this population obviously matters. And we see this occurring because, many providers with a buprenorphine waiver still don't prescribe buprenorphine. So I sort of said in a previous slide, maybe if we just get everyone waivered to prescribe buprenorphine, that'll help with stigma. Well, it might, but a lot of people who are waivered have the ability to prescribe buprenorphine to people with an opioid use disorder. They do not do so. So is that a stigma issue, or is there some other issue going on there? Well, stigma definitely plays a role in it. Maybe people are saying that patient population is too complex. I don't want to deal with the DEA. So there's still a barrier there that, we're not doing a great job with provider buy-in. And there's probably other barriers we haven't thought of. So that brings us to our next component of this workshop, where it's what you all think. So we're going to put everyone into breakout groups and kind of reflect on the stigma interventions I've gone over. So the purpose of this is to reflect on what we know about stigma interventions, which is not a ton, right? I summed it up in kind of like 4 slides. That means we don't know a lot. And you're going to talk to other workshop participants about your impressions of these interventions, what you like, what you don't like about them. In a breakout room of 4 to 5, it might be a little bigger because we have good turnout. Thank you for coming. So what you're going to do is we're going to put you into breakout rooms. You'll have a pop-up that comes and you'll join that breakout room when the pop-up comes. In your group, you're going to assign one person to be the scribe, so the note taker, and you're going to get a Google document with the instructions and a reminder of all the interventions. It's okay if you don't remember everything I went over or you stepped out for a minute. At the end of the document, there's a summary of all the interventions. And then one person could be the speaker who will report back to the larger group after the breakouts, and we'll discuss the interventions in your breakouts. So the breakout room discussion questions are, which interventions do you like the most and why? Which are maybe the most feasible, which aren't always the ones you like the most? Which interventions did you not like? Are there other interventions that researchers haven't considered for reducing stigma towards substance use that you think could work? What are those? What are some barriers that might impede stigma interventions that you like, and how could you overcome those barriers? So in your Google document, you'll see a table like this, where you can just fill in your sort of group responses about each of those. And then we'll report back after the breakout rooms. So we're going to have Christina or Anne-Marie open the breakout rooms that you can join. So when you see the pop-up, please join it, and then we'll send you the Google document when you're in your breakout room.
Okay.